Welcome everyone to the North Carolina Maternal Health Innovation Community of Practice. This month's topic is transitions of care and the ACOG AIM discharge bundles. So we've put in the chat some attendee information to submit. If you wouldn't mind clicking that link and giving us a little bit of some information about you and your goals and objectives for joining this community of practice. That really helps us as we plan for future events. I'm going to turn this presentation over to Dr. Havey at ACOG, who so graciously offered to not only present and introduce herself, but to help lead this discussion of transitions of care. And then at the conclusion of this, we will have our Q&A and open for discussions. So in the chat, you can also hold your phone up to the screen to capture the attendee information. All right, I'm going to stop sharing and I'm going to turn it over to Dr. Havey. We're so excited to have you. Thank you for joining us.
Thank you so much for inviting me. And you can see my screen, yes?
Looks great and you sound great.
Awesome. And first of all, I don't actually work for ACOG. I am contracted by them. So I just want to make sure you're aware of that. This is my introduction slide. This is our goat, Adele. And you'll see at my house, goats ride in the car. That's actually a truck, but they're part of our family. And you all can read my bio and see on what year I did whatever I did and what my credentials are. But I really think it's important for people to understand why we come to the work. And so we all wear so many hats. I'm a nurse, a mom, I'm a nursing faculty, I'm an administrator at a hospital, I'm a farmer, I'm a knitter, and I do all of those things with the idea that I can make the world better. So when I was 24 weeks pregnant with twins, I was laid off from my job. I was not a nurse at the time. And I went through an antepartum and peripartum course that was difficult. Those twins are going to be 18 on Tuesday. And so when they were 4 months old, I went to nursing school. And I have had a abiding interest in peripartum care and have worked my entire career towards understanding how to make birth safer for women, both during the prenatal and peripartum and postpartum area. So the objectives for this talk are to review the state of postpartum care in the United States, review the AIM postpartum transition bundle, and describe one integrative program of postpartum care that can help. So I don't have any conflicts of interest other than I'm contracted by AIM to resource the bundle, the discharge transition. So with that, we'll just get started. I would like to give some credit for some of these slides that if you were on the AIM webinar were presented by Dr. Lin Yi, and I have borrowed some of them for this presentation. Postpartum care in the United States. You can't go very long at all without seeing a major headline about how we are failing mothers in this country. We are for an industrialized nation, we do not serve our birthing people well at all. People are dying in childbirth, and as we're going to talk about that, more than half of the people dying of a pregnancy related event are dying after childbirth in the postpartum section. Postpartum is a complex time, and all of these things are intertwined. Your emotional well-being and mood with your infant's care and feeding, how you retain your sexuality and think about contraception and appropriate birth spacing. What medications are you using? Do you have substance use disorder? How do you physically recover from childbirth if you don't have parental leave? And making that all very much harder is the natural sleep loss and fatigue of new motherhood. So the leading maternal health problems within 2 months of delivery, they've characterized this as major and minor. The blue is the major, everything from sleep loss to breast infection and everything in between. I think about those pharmaceutical commercials where they tell you what this new drug is going to do and then tell you you might have all of these things. And I think about someone holding up a new baby saying, you know, you could have this beautiful baby, but you're also may have, you know, a breast infection and hemorrhoids and painful intercourse and feelings of depression and a backache. And you wonder if people really understood the complex nature of the postpartum period, why are we not doing more to help mothers? So the percentage of women delivering who have a postpartum care visit, many of our states don't report, so we have no idea. Um, many, you know, the blue states have above 66%, so above 2/3, whereas the yellow states, of which there are much, have, you know, a quarter to half of their women. Um, North Carolina is right there in the middle with 61 to 66%. That means up to a third of your mothers, or 30 out of every 100, are not having a comprehensive postpartum visit. When we talk about quality improvement targets, when we talk about maternal health, mostly we are talking about the iceberg, you know, what's above what we can see. So women who die in childbirth or have severe morbidity in childbirth. We do not talk about the maternal chronic medical conditions, which is more of a transitional and ambulatory focus. So, you know, it's not as headline catching, right? And so it's hard work. There's a tiered postpartum morbidity structure where you know, we have the very top as you're at risk for maternal mortality and morbidity. Then you are at risk for pregnancy morbidity, so mortality, morbidity, and then you're at risk for long-term issues. And then there's the routine preventive care for all pregnant people. So you have this risk level that we are only really able to look at the top part, right? All of our interventions seem to go to the peak of the pinnacle there. This is what I alluded to when I first started speaking. The timing of pregnancy related deaths in the US, 51.7% of the deaths in maternal deaths are postpartum. So more than half of women who die as part of a pregnancy related event, it happens more than 24 hours after they give birth. That was staggering to me. You know, as a nurse at the bedside in labor and delivery, I firmly understood my charge to keep women safe during delivery. I did not have a really good understanding that that wasn't enough. The unmet postpartum mental health needs and understanding the stage at when maternal suicide occurs was also really um, heartbreaking to me. We're talking about the postpartum period, you know, when, you know, we talk about the newborn period. Some people talk about 28 or 42 days being the newborn and then they're an infant. After that is when most of the maternal deaths from suicide occur. So this is, you know, after you've had your 6 weeks postpartum visit or 10-week postpartum visit, and you're kind of floating on an island all alone. There's no routine checkup that you have, and often you can feel very alone. So we often are talking about postpartum hypertension, and we are just beginning to understand what that means for after pregnancy. If you have preeclampsia or postpartum hypertension, it doesn't go away when the baby comes out. We used to think that, you know, we used to hear a lot that the treatment is delivery. We just have to get the baby out and then she'll be fine. That's actually not true. And there is, as everything, there is an equity perspective that the lens we don't look at things through very well. So the idea that we should be doing blood pressure checks after a woman goes home is kind of new. And and very important. And I don't think people understand. I know birthing people don't understand. They feel like if they didn't have hypertension or a comorbid, um, cardiac event prior to pregnancy, they'd had it while they're pregnant. Well, they're not pregnant, so they don't have it anymore. There's this abiding philosophy that they fixed it, and they don't understand the risk. Gestational diabetes, you're 50% more likely to develop diabetes in your lifetime, even if your sugars go back to normal when you deliver. People don't really understand the long-term connection. So we also have inadequate transitions of care. We don't have electronic health records that talk to each other. So if you see a doctor for your post, peripartum care, and your regular doctor, if they're not in the same system, then they often don't have the information they need to take complete care of you. We don't really have standards for comprehensive postpartum care, and what that means that differs regionally and sometimes within a region by facility and or doctor or provider of care. We don't really communicate well about pregnancy related events and risks, and as always, there's an amplified effects of social determinants and racism. We have insurance churn. The combative nature of not wanting to pay for tests that are really needed, or an inordinate number of hoops to go through in order to get a needed event, or people who don't have insurance or have high deductible plans that think, is this really necessary? Do I really have to have this? It's gonna, it'll be fine. Pregnancy is seen as a life event, not a medical event. And while the physiologic birth person in me loves that, the nurse in me is afraid of that, right? Um, we used to have a bumper sticker on the top of labor and delivery. It says birth is not an illness, and a nurse had written underneath, but it can jack you up. And that's kind of how I feel about it, right? Birth is not an illness. However, it is, your health during pregnancy is a really good predictor of what your health is going to be lifelong. um, Also, we don't really engage with primary care. We're very siloed about the fact that we take care of women from the time they find out they're pregnant until they're discharged from care, anywhere from 6 to 12 weeks postpartum. And then we don't see them again until they are pregnant again, which we have lost a lot of opportunities to affect that woman and her care. So patients and providers both understand that there are challenges to postpartum health care. The providers have a non-clinical task burden. They are training gaps. Physicians aren't trained in some of the normals of pregnancies, and they don't adequately allow for collaboration with doulas or um, uh, kind of home care providers in pregnancy. There's not enough overlap. We think about this in a way that's very siloed and doesn't do justice to women and birthing people. Um, and they're at all levels, from the ability to schedule an appointment to insurance limitations, childcare, right all the way down to health literacy and mood issues. Um, this is an unbelievable window of opportunity in order to affect the life of the birthing person and the child. We know that pregnancy events are predictive of future cardiovascular morbidity. We know that it's often you'll have access to insurance through the child health insurance program during pregnancy that you might not have before and after pregnancy. Um, People are motivated and activated, and they're very engaged in wanting to do the right thing. Um, and the interventions in the peripartum period can have long lasting maternal and family health benefits. You can teach people different ways of being, and they're open to it in pregnancy and often continue that way of being. And it can improve future pregnancy health and or prevent future pregnancies if that is what is needed. We have to do the work of recognizing postpartum health as a public health priority. This is important, and it's as important as peripartum maternal morbidity and mortality, because as we saw before, more than half of women die after 24 hours in the postpartum period. So we've talked about a lot of focus areas in this country. You know, we want to decrease cesarean birth for low risk um, birthing people. We want to increase the use and quality of postpartum care and increase the use and quality of well child visits. And none of those can be done as one thing. There's an entire system of being that needs to be looked at, and we need to collaborate across all of these areas in order to get to do the heavy lifting of getting this done. So some interventions in the postpartum period that we have looked at in order to make that transition and care better is patient navigation, nursing care management, tools for scheduling. So a birthing person can go on their phone in their MyChart app and say, hey, I need an appointment, or they can send a message to their provider. They don't have to wait online and get back. You know, there's lots of different interventions within our technology tools that could help. Really investing in home visiting programs, understanding where people are at and what environment they're in can really help. We really need postpartum care plans and warm handoffs. We need to be able to say, I'm following this person and I'm transitioning the care, but I'm not giving her away, right? I still have an obligation to understand the full picture of care that we're providing. And then this postpartum discharge transition bundle is trying to help. You know, the unifying theme is that we need multidisciplinary coordinated care teams with a systems focused, patient centered process that includes attention to social and medical determinants of health. That's a lot of words for saying we need to do the right thing for every person on every unit every time. And we need to understand what the gaps are and have a unique opportunity to kind of get on the same page and pull forward. So solution-based principles, we really want to target the transition where people fall through that crack. We want something to be able to function despite the limitations we found in the healthcare system. We want something that actually understands the social determinants of health and where we might need more or less resources. We want to center the maternal and family experience and center the margins. We want to bring everyone to the middle. We don't want boutique care and we don't want no care. We want everything in between. So what is a bundle? A patient safety bundle is that every patient, every time. The Institute for Healthcare Improvement talks about the fact that this is not new. We don't put new things in a bundle. A bundle just puts all the things together that if you do all of them together, you have an increased chance of affecting change. The way we talk about bundles is we need 3 levels of interaction. We need local quality improvement, we need an engaged system, and a political engagement. We have to understand the equation where equity is involved and how to make political pressure in terms of getting the resources we need. So these were the guiding principles and the critical importance of the postpartum bundle. We need to optimize safety for every postpartum person with a standardized approach to the postpartum transition process that limits the ability to fall through the gap. We understand that the care in the US is fragmented, and that's a major challenge. But by focusing just on this transition, maybe we can shepherd people into the right area and get them the right care. This started with a committee opinion in ACOG called Optimizing Postpartum Care. It was then that the idea was formalized in writing that to optimize the health of women and infants, postpartum care should become an ongoing process rather than a single encounter. They should have additional contact with maternal care provider before their 8 or 10 or 12-week visit. And the assessment should be followed up if there's ongoing care needed. You don't just tell them at 12 weeks, go see your doctor. you're still their doctor, you're still their provider, and they need a handoff. And they need a comprehensive postpartum visit, including a physical exam, no later than 12 months after birth. So the bundle always includes 5 parts: a readiness, which is a unit focused, a recognition and prevention, which is patient focused, response, which is event focused, reporting and systems learning, which is again unit focused, and respectful care, which is every unit provider and team member focused. My favorite quote ever, Christy Allen: a bundle's just a piece of paper until somebody applies the implementation strategy and process to it. It's a tool like any other tool. It's not a magical unicorn. You can't say, oh, we're doing the AIM postpartum bundle, so it's going to work. We're going to do the things. It's not about the bundle. It's about all of the parts coming together to work to make women and birthing people safer. So the bundle is a piece of paper. It's really good ideas from really smart people, and it's going to take all of us working together in order to stitch together what's needed in order to affect the lives of women. So readiness, every unit. We need to develop and maintain referral resources and communication pathways. This is that care management part that we talked about. Maybe it's nurse navigating. Maybe it's, EHR tools. We need to provide education to the entire complement of our staff about the importance of the postpartum care and postpartum period and how to screen women during that period. As part of that, the postpartum care plan, the maternal health safety check key elements, there's actually a document where you can go through and make sure that we are checking all the different parts, and that we're doing it with every woman every time. For every patient, we need a system for scheduling postpartum care that is either virtual or in person. And we need to schedule it before they leave the hospital so they know when their visits are and are, and that they have the resources needed to get to those visits. Whether that is a access to a device if it's a virtual visit, or access to transportation if it's an in-person visit. We need to screen each patient for risk factors, and when we find them, we need to do something about it. And we need to do that before they're discharged. One of the big places for collaboration is with the emergency department. Often women who are having a postpartum complication don't understand that it's a postpartum complication. They're dizzy, they don't feel well. So they get to an urgent care, an emergency department, who maybe doesn't ask if they've been pregnant in the last 30 days, 4 months, year. And they do some workup and they decide, she's fine, or blood pressure's a little high, but 160 over 90, it's not really that bad. You should just follow up with your primary care. When you add the fact that she has a 6-week-old infant at home, that's a recipe for disaster. So making sure we do this education across disciplines, especially where birthing people come into the system, is very important. So our response about events, we need to provide the robust patient education prior to discharge. That includes the fact that if you feel the need to go to the ED, you should make sure they know you were pregnant and that you have you may be having a postpartum complication. And there needs to be a comprehensive postpartum visit within 12 months after delivery. Making sure people understand their risk in a way that is not scary, but make sure that they do understand what to report and how to report it. Making sure that their partners or support people also get that education, because often women don't see what's happening to them. It takes a partner to say, hey, you really seem off. Are you okay? I noticed that you can't stop crying. Is everything okay? I noticed that you're putting the baby down and walking away. Is that so that you can get a breath, What is happening here? Do we need help? Do we need, so oftentimes, oh, you look a little off kilter. Are you dizzy? Are you, so we need to make sure that we're educating families and support networks. As far as the unit-based focus, reporting and systems learning, multidisciplinary huddle for postpartum patients that have high risk complications. We should make sure that there's a care plan and a plan to follow up and a plan for what happens if we don't hear from that woman. So if we can make all the appointments, but if that person does not make the appointment, what's going to happen? Who follows up? How do we keep that, keep, you know, how do we keep it going? How do we make sure that there's a follow up there? And also the comprehensive postpartum visit, we should have a template. Everyone should be doing it the same. We should understand all the different systems that need to be evaluated and screened. This is also goes back to our understanding contraception choices and our partners in emergency medicine. We need to really have everyone along the care continuum understand the basics, right? And know that when it's a postpartum woman, we should escalate this and verify that what we know is true, right? If you have an ED patient that it happens to be postpartum and you think they're fine, have you checked with an OB provider? Right? Have you said, hey, I have this person, their blood pressure is 160 over 99, but I think they're okay. I'm just gonna have them follow up with their doctor, right? Is that okay? Right? You hate to add layers to care, but for safety, we really need to make sure that either as part of emergency medicine fellowships and residencies, this is talked about with a equal fervor as is how to reduce a displaced elbow. We need to make sure that this curriculum exists. Respectful care. This is a new element for our bundles. We also want to make sure that the postpartum person and their identified support network are part of the team and they're respected and their wishes are respected. Sometimes this is really hard. It's hard to connect with people sometimes. It's hard to say, it's hard for providers and nurses and other people to step out of their own expertise and put themselves in the shoes of the person across from them. And so this is really important. The New York City standards for respectful care at birth are phenomenal. If you haven't, they're online if you haven't had a chance to review them. And if you Google respectful care, there are a lot of resources out there. We need to empower women to understand that they know their body better than anybody else and to report and own that. And we need to listen. So the innovation that I'm talking about has been done in this little critical access hospital for nearly 20 years. And it's called a care connection visit. And it takes some of these elements and puts them together. So 24 to 48 hours after discharge, every mom comes back to the hospital with their newborn to see a nurse. So this is the table that's from that optimizing postpartum care for moms and babies. And the optimal, traditional is 6 weeks. We want a BP check with 3 to 10 days if you're a high risk, right? And follow up, contact with all women. We structured the care connection visit to be 24 to 48 hours post discharge. If you have hypertension, you also get a 7 days post discharge BP check. You get an office visit at 2 weeks and then an office visit at 6 weeks. And then out here, you're not discharged. Based on this office visit, you get scheduled for the appropriate timing of your comprehensive postpartum visit. You leave with a handout that tells you when your postpartum visit is. You have a Porter Care visit on this day at this time. It's going to either be in person at the birth center and or it's going to be telemedicine. And then we actually say you're going to have your blood pressure checked at that one or you're not. The BP check is so that we're triggered to set up the second one, which is a 1-week blood pressure check. This is the doctor's office. And depending if they can't get the woman in at the doctor's office for a nurse visit, she comes back to the birth center. Then we have your 2-week visit. That's either in person with a BP check or a telemedicine. And then your 6-week visit. So you leave with all of these visits already scheduled, and there's one piece of paper you can go home and attach to your fridge with all of the dates on it. Your newborn also has this visit. So you come back with your newborn, and we obviously don't do an in-person newborn visit and a telemedicine mom visit. So this is actually tells you how that's going to be done. And then we make your first appointment with your pediatric provider. That must be in person. And we actually list it on your appointments. This is the back of that same form. If you have high blood pressure, it asks, do you have a cuff at home? If not, we're going to give you a prescription for one before you're discharged. Do you have a new prescription for blood pressure medicine? If so, is someone able to pick that up for the pharmacy? We're going to call you and talk to you and make sure that you have and understand how to take that medicine. This is how to take your blood pressure. So we're sure that we've told everyone the exact same thing about how to take an appropriate blood pressure in a postpartum woman. This is, we've given you how to decide whether or not you need to call your provider. These are their notification times. We also actually put a picture of the post-birth handout that we are handing to you. We have both the handout and the magnet that we hand to people, and we're saying, please remember you have this handout that has all these other things on it. So as part of, on the front page of this, you have all of your appointments. On the back, you have how to take your blood pressure, when to call the provider, and a reminder you have this other thing to put on your refrigerator. This is how we decide whether you can have an in-person birth center or telemedicine. At any time, a provider can say, I need this visit to be in person without any reason. You got a hunch? Sure, we'll do it in person. But so we decide whether or not it can be telemedicine, and this is the algorithm that we use to do that. As you can see, the newborn assessment and teaching that we complete in our electronic health record is robust. We're going to do another TCB. We're going to check the transcutaneous bilirubin of that baby. We're going to weigh the baby. We're going to ask you about feeds, and we're going to ask you about voids and stools. We're going to, this allows our first pediatric visit to be at the 1-week mark instead of at the 2 or 3 day, because we do all this in the hospital. If you're breastfeeding, we are happy to provide lactation assistance, although we don't have lactation consultants. We have trained nurses as CLCs. So every nurse that does postpartum assessment has the training they need in order to watch a breastfeeding and help positioning and or optimization. We then make a follow-up plan and we chart it. What's going to happen? Are we going to routine follow-up, go to your visit? Are we going to actually refer you to the MD now, and we're going to call them and tell them you're on the way? And if you are a no-show to this visit, we actually notify your doctor's office because you need a visit before the 7 days in order to optimize the health of that newborn. We also do a complete maternal assessment, right? We do a blood pressure on every mom. We do pulse, temperature. We look at sausage toes and rate your edema. We actually talk about, what was the hardest thing about last night? What did we not tell you that you wish you would have known? We start every visit with congratulations, you made it. You kept an entire human alive at home without us. Pat yourself on the back. Good job. It's hard. So we celebrate that and invite people to tell us what was hard about it and what supports they put in place, to ask questions. We ask them if they need to revisit any of their postpartum teaching. We remind them that they have the booklet. They also have it completely on an app. We make sure they can open it and see it. We then go through the post-birth assessment and ask about those things. We remind them we have a laminated post-birth, and we say, did you put this on your refrigerator? Did you tell your partner, your support people about it? And then we go through the teaching and we figure out what your follow-up plan is going to be. Are you just going to keep your regular postpartum appointment? Are we going to call the doctor and or midwife and see if you need to be seen earlier or differently? Are you going to be admitted? That's not here, but sometimes we do admit people for postpartum preeclampsia right from this visit. And that's the follow-up plan. This is the thing everyone wants to know. This is part of the global fee. How do we pay for it? How do we make sure we have a nurse available? We're a critical access hospital, but we do 350 to 375 births a year. That's a lot for our size. And we have the support of our hospital administration, and we list it as a community benefit on our 990. And we write off everything except supplies. So this is a free visit to everyone. We consider it included in your global fee. We don't do any charges. We need to remind birthing people that you have an entire care team. You have many, many people that care about you and want you to be well and happy. And you can get help from many of these people. During the beginning of the COVID crisis, we had pediatricians taking blood pressures for us. So women didn't have to go into a variety of places. We trained their medical assistants how to take a maternal blood pressure. And while the newborn was there for their visit, they would actually take the mom's blood pressure and call over to the OB's office and say, hey, I have this person, here's the blood pressure, what do you want me to do with it? There was an incredible amount of collaboration in order to keep everyone safe and keep them out of the hospital and out of areas where they didn't need to be. So we need to remind and we need to build these robust systems and make sure that every part of this care team understands their role in it and that they may be called upon in order to affect this change. Next steps. Just like Christy said, bundles a piece of paper until we do the hard work. So the next steps are assessing what you already have in your toolbox and what things you need to create or provide or build. What connections can you build? What bridges do you already have? What are a little rickety and you need to shore up? This is the time to build that. And this is Max, the goat.
Thank you, Dr. Havey.
And with that, that's the end of my presentation.
Thank you for your presentation. We do have a few questions in the chat box. I'll go back to the first one. I think you kind of provided several examples to that one, but the first one was, how can I help the practices in my region improve transitions to well woman care?
I think what we're talking about is really task force space, right? You need to get all the voices and the stakeholders at the table. Often it's really hard to get everyone at the table, but as many people as you can, get them at the table and talking about what could we do? What is available right this minute? And what could we build?
Thank you. Our next question is, how is the maternal and infant assessment shared with the newborns provider in the hospital and as a part of the discharge plan that goes to both mother's provider, postpartum, and infant outpatient?
So if they are in network, we are all in the same EHR and it is charted in the chart. If not, we actually print out that assessment as a report and we give it to mom to bring to her, her newborn's appointment. We also do a lot of calling and making sure people are aware. If we have concerns, we will actually provider to provider or nurse to nurse call the office and say, hey, this person was here. There was this concern. I just want to make sure you're aware of it. We just do a lot of follow-up.
And then the next one, how is the population level impact of comprehensive collection of practice being measured, assessed, and reported? So the impact, evaluation, and publications.
Of this particular intervention or as a whole and for postpartum interventions? This is happening in Vermont, and we don't have good data. We had a cobble together, the screenshot you saw were actually a Meditech, and we couldn't get data out of it. We've just transitioned to Epic, and we are starting to pull data and figure out how to publish about this. This is a sleepy little town in Vermont that's kind of a little bit of a unicorn. But if we can figure out how to get it done, I'm sure other people can too.
How long is each visit? And do you find it's harder to get moms back in the first 1 to 2 days? And do you need to train nurses who provide this comprehensive visit?
So we have about a 94% return rate, which is kind of amazing. If we transport mom or baby to a tertiary care center, we also invite them after discharge back to a Porter Care Connection visit. So they may be there 8 weeks in the NICU and they come home, we have them call us, they come in, they get a chance to debrief their care and their transport. We ask them if there's anything we could do differently or better, and we tell them good job. You know, this is an entire community undertaking.
Has the care connection visits been adapted in the rural settings, and how has the issue of transportation long distance been addressed for patients to make it back to the OB provider?
So in Addison County, Vermont, we are a rural area. The hospital is in a town with about 10,000 people. That includes a college. So when all the college kids are here, we're about 10,000 people. I live in a town of 848 people, about 25 minutes away. So this is a rural setting. We find that we do have transportation. We have Medicaid cabs. We have an Addison County transit bus that goes around to the different communities. We have a robust community effort. We work with the Parent-Child Center. We have Department of Health integration. We really are kind of, we are far along in that collaboration piece. And we have many community agencies that are with us and helping. We're very lucky in that regards.
What measures do you hope to pull from Epic?
So we are hoping to pull visit statistics. We're hoping to pull number of times we have to refer to a higher level of care, whether that's a visit with a doc before their scheduled visit. The number of times we have to reteach about a specific topic, and whether or not we should change our discharge teaching in order to attend to that. Some of these things we were following and collating by hand from Epic or from Meditech. We were actually going back and doing chart audits to look at what the teaching we were providing. That's how we got our nurses all to be CLCs and got the okay to pay for that. Was we were doing mostly lactation teaching. I like to say we're not baby friendly, but we're real nice to them. And we have above a 90% initial breastfeeding rate. Our rate at 90 days is lower than that. It's in the 70s, but we consider that actually really high, given that some of our moms are going back to work at 2 weeks, which is heartbreaking. So, you know, we wanted to see if we could affect change in that. When they get to their postpartum visit, are they still breastfeeding? So we've been following some of these statistics by hand. It's just arduous.
Questions keep going in.
There was a question I didn't answer, though. You already asked me. One of them is, do we train the nurses for these visits? So we are a LDRP. And so the same nurse that admits you for your labor also takes care of you postpartum and does Porter Care visits. So there's no special training, but it's a continuity of care. We find that's important.
Can you explain Porter Care visit? again? There's a question about what is Porter again, and
Porter is the name of the facility. I usually take that out, but realized I didn't take it out. That's why we call them care connection visits in a presentation.
have you ever had these nurses make home visits, and would that be covered too?
So we have not had nurses make home visits, although we do Addison County Home Health and Hospice. We do partner with them if someone is unable for some reason to come back for a care visit. We do robust home health care referrals. A birthing person might actually have home health care and this Porter care visit.
What are the 5 most important pieces of information about either mom or baby that you feel have been the most useful to communicate to future care providers after this visit?
5 most important, that's a great question. Part of the reason we have it is so that we can do a visual assessment of the dyad, right? I think that as a nurse, we get a lot of assessment information by talking and interacting with moms and babies. And I try really hard not to say moms and babies, because we also have, adoptive or parents who have had a baby with a surrogate come back for their postpartum visit as well. We don't tend to take their blood pressure, but we do the full baby stuff. But, I think it's really important to make sure people understand, were people satisfied with their birth experience? Do they have remaining trauma that needs to be talked about? How is their physical healing going? Are they tender? How do they move? Are they, what their mood is? And any outliers as far as vital signs. So that's the top 5, I think.
Are there women delivering at your hospital that are coming from other counties?
Yes, other counties, and we get them from up to 3 hours away in upstate New York. So we have a large catchment area. We have our NTSV rate was, I think, in the 14% at some point. We have a midwifery-led service. There's always a midwife on first call, and we do a lot of physiologic birth, and we do a robust VBAC. And so we get women from a large area when a rural hospital stopped doing TOLACs. And yes, we do coordinate with those areas. We call the New York Department of Health. We make sure that they have home visits set up. If we have to do a video visit because they're so far away, we make sure they're hooked up to whatever we can find in their area.
And with that, do you have a formal relationship with a higher level of care, and they collaborate with you in QI?
Yes. So we work with our academic medical center, and we determine our quality aims every year. We have a transport conference where we talk about every transport that we've made to a higher level of care. We also do some cross collaboration. So we have an OB birth center meeting monthly. Quarterly, the pediatric team joins it, so that we meet as a cross coverage team. And we find that has gone a long way into making sure that people understand the different perspectives and what might be important to one versus the other.
Has COVID had an effect on the success of these visits? And if so, what were they?
I missed the first part.
Has COVID had an effect on the success of these visits?
I would have thought this would have been a severely limiting, and actually, I think people are more in tune to the fact that they want to remain well. And so we have not seen any dip in them. We have done more remote visits than we had prior to COVID. We were just dabbling in telemedicine, and really for people who were 3.5 hours away, or, that kind of thing. But if we have a robust relationship, use their 3rd baby with us, and it's going to be -12, and you don't want to come to the we were happy to do that over video and ask you how it went and watch your toddler crawl over your back while you're trying to nurse on the sofa. You know, it, it's about having the connection, not doing it a certain way.
How do you partner with maternal, infant, and early child home visiting providers like Nurse Family Partnership or other care managers that Vermont may use?
Actually, Nurse Family Partnership does not have a Addison County outreach. They're in Northern Vermont. We do partner with the Parent Child Center, which is our Addison County kind of supportive agency. We invite them to staff meetings. We make sure if they have changes in their programming that we are aware of it. We work with case management and care management in the hospital in order to have quarterly is the goal meetings to kind of talk about what in the community has shifted or changed and what do we need to be aware of. You know, we are happy to partner with anybody if it will help the dyad.
And how is the digital access in Vermont?
So it's really depending. Most of Addison County is connected. There are some parts over the gap that have limited access to a digital footprint. We have not found that to be a problem in our area. It is a problem in other parts of Vermont. We actually got a grant. And so if someone doesn't have a device, we have a bag with an iPad and all the things they need to set it up that we actually can give away. So, you know, they're usually identified in the prenatal period because they do a telemedicine visit for at least one of the prenatal visits in case they have to be telemed in the future. I forget, it's a standard visit. It must be like 24. It's not 28. It's not 36. Must be in the 24-week time. They do all of them videos so that if you ever have to have a video visit, we're sure we can get to you, you understand what it is, and you have an opportunity to kind of try it out. And so we assess, do you have the ability to do that? Do you have a phone that's video capabilities? Do you have a computer? And if not, we, like I said, we have this grant for digital devices, and it's a backpack with an iPad.
Yeah, I think we have one more question and then that'll be our time. Kristen?
Thank you for this. It's so exciting. You mentioned templates for example, a postpartum visit and maybe standardized AVS components. Does AIM or ACOG have plans for offering those?
I'm going to actually throw that one to Amy Ushry. Are you on? I know that the comprehensive care plan is something I got from the ACOG website. So it already exists there, that comprehensive postpartum care plan visit.
Source you were asking about if we're planning.
Yeah, well, and I'll just reply that many of us, I think, would love to contribute to offering examples of these for sites to potentially implement or adapt. So we could follow up if
that's fantastic.
Well, thank you for your time today and sharing, and thank you for responding to those questions and everyone that took the time to join us today. Suzanne has dropped a link in the chat box for our evaluation for today's session. And we will also be having our next community of practice coming up in February. And the topic for that is going to be on measurements. And we will also be following up with Dr. Havey to see if we can have some more to help with the build of different tools. Suzanne?
Yes, so in the chat, I'm putting our next community of practice link, and then a few more updates. I'm going to stop recording now.